My name is Bethany Cole, and I'm the Global Projects Manager on the Fistula Care Plus project at EngenderHealth. And before we get too far into the webinar, I'd like for someone to chat to us in the chat box to make sure that you can hear me. If anyone can just, any of our listeners out there, we have a pretty good group here today, and I want to make sure that we're all connected.
Okay.
Okay, good. So we've got one person. Anyone else that can chat to say if they can hear us, please?
That's fine. Okay.
Okay. Oh, good. Okay, great. All right. So we've gotten somebody just Skyped me actually to say that they can hear. So let's begin. I'm so excited to talk today with three colleagues who will be discussing the needs of women after fistula repair. We have Dr. Alison El Ayadi, Mr. Moustapha Diallo, and joining via a voice recording, we have Dr. Rose Mukisa. Dr. El Ayadi will report on a study recently conducted at Makerere University in Uganda and the University of California, San Francisco. This study obtained longitudinal data from repaired fistula clients 12 months after surgery. The study sought to develop a measure of post-surgical reintegration success and to better understand physical and mental health challenges among repaired clients to inform evidence-based reintegration programming. Before I turn over to Alison, a brief word about Fistula Care Plus. Through USAID funding, Fistula Care Plus and its predecessor project, Fistula Care, in partnership with other agencies and projects, supports 37 treatment facilities where women have access to surgical repair or non-surgical intervention for fistula. To date, more than 35,400 surgical fistula repairs have been supported, and 26,000 healthcare workers have been trained in prevention and treatment of fistula. To read more about our program's accomplishments and lessons learned, please visit our website or follow us on Twitter. And I hope that you can all stay till the end of the webinar because I have a special announcement that, that I look forward to sharing with you at the end of the webinar. So for today, in the area of maternal health, fistula remains less researched and has a smaller evidence base than other conditions. Where evidence does exist, it is nearly exclusively around outcomes of clinical interventions and especially surgical outcomes. I'm excited about today's talk because we're going to hear about research post-surgery and post-repair. What happens to women after they are discharged? What are their needs when they return home? And how can projects and healthcare workers better meet these needs in a holistic way when women present at health facilities with fistula symptoms? So to that end, let's get started. Our first speaker is Dr. Alison El Ayadi, who is an assistant research scientist at the Bixby Center for Global Reproductive Health at the University of California, San Francisco. The research program focuses on reducing maternal health disparities in the developing world through interventions targeting structural, social, and interpersonal factors. She holds a Career Development Award from the National Institute of Child Health and Human Development to develop and pilot test a comprehensive intervention to improve women's recovery from obstetric fistula. She received her doctorate from Harvard University and her MPH in reproductive health from Tulane University and her BA from Colby College. Okay, Alison, over to you.
Great. Can you hear me, Bethany?
I can hear you very well, and I hope one of our participants will chime in the comment box to confirm that they can hear you too. So please go ahead.
Great. Thank you so much for having me, and I really appreciate this opportunity to share the results of our work, and I'm looking forward to having an interesting discussion after the presentation, drawing on the experiences of the webinar attendees on the implications of our research and how we can best integrate the lessons that we're learning into fistula care. Next slide. So today I'm presenting some preliminary results of a collaborative project between investigators at Makerere University, College of Medicine, and Mulago Hospital in Kampala, Uganda, and the University of California, San Francisco. Previous research on obstetric fistula has elaborated the severe physical and psychosocial sequelae of prolonged obstructed labor, which in addition to resulting in obstetric fistula is associated with a wide range of gynecologic, skeletal, neurologic, and dermatologic injuries, and is associated with very poor mental health, stigmatization, and marginalization, which highlights the important need to rapidly link women and girls affected by obstructed labor injury complex to treatment services. However, as Bethany noted in the introduction, much of the research on fistula has focused on the pre-surgical period, and over the past decade, access to fistula surgery has substantially increased. More and more women are being treated for obstetric fistula. However, despite the evidence that women living with fistula experience very challenging physical and psychosocial experiences, we really know little about women's recovery trajectories and their experiences of reintegration post-surgery. Most of the post-repair data that has been collected is facility-based, and the follow-up has been informative. So what I mean here is that routine follow-up data represents women who, or does not represent women who feel that their concerns have been resolved largely, or those who are unable to return for follow-up care. So these women are often not represented in routine follow-up data, which limits our understanding of experiences of all women post-surgery. And so it's important for us to follow cohorts of women to understand what's happening following surgery. This is particularly important because of data suggesting that women who continue to experience physical disabilities have difficulty reintegrating to their families and communities. So our study sought to contribute to the evidence base around the post-surgical period among women and girls affected by fistula, and to develop and validate a measurement instrument to assess the level of reintegration, because the lack of a standardized post-surgical reintegration measure impedes measurement of reintegration across time and across contexts. Our reintegration study was based in Uganda, so I'd like to just share a few statistics to contextualize our findings. Data from the 2016 Ugandan Demographic and Health Survey show that 74% of women who gave birth in the past 5 years delivered with a skilled birth attendant. This is a substantial increase from the 2011 data. And these data were just released a few weeks ago. So unfortunately, the other statistics that I have on this page have not yet been updated from the 2011 demographic and health surveys and service provision assessments. So data from these surveys shows relatively poor access to emergency obstetric care across Uganda, with only 9% of health facilities offering all 7 basic emergency obstetric care signal functions or life services. In 2011, Uganda had the highest proportion of women globally reporting having experienced incontinence symptoms among all countries that have recently used the fistula module. And this included high regional variation, which ranged from 0.6% to 4%. Uganda's Ministry of Health is prioritizing the prevention and treatment of fistula as an issue of significant public health importance, and a fistula technical working group was established by the Ministry of Health and key medical and social service partners in 2002. Next slide, please. Our study followed an exploratory sequential mixed methods design. That is, we conducted a qualitative study component followed by a quantitative study component. And the purpose of our qualitative work was to develop a nuanced understanding of women's experiences and priorities for post-surgical reintegration. For this component, we conducted 16 in-depth interviews and 4 focus groups among 17 individuals for a total of 33 participants. Qualitative participants needed to have undergone surgery for vesicovaginal or rectovaginal fistula in the previous 6 to 24 months, live within 100 kilometers of Mulago National Teaching and Referral Hospital in Kampala, and have provided a telephone contact for recruitment. Next slide, please. The qualitative data were collected from June to August 2014. Based on our qualitative results, we developed a measurement instrument to assess reintegration. We then recruited a small longitudinal cohort of 60 women to validate this measure and to capture quantitative data on trajectories of physical and psychological recovery. I apologize, Bethany, can you please put me back on the exploratory sequential mixed methods design slide? Thank you so much. So these 60 women represented the majority of women treated for obstetric fistula at Mulago Hospital over the period of December 2014 through July 2015, and data were collected through August 2016. Participants in the quantitative component were enrolled at fistula repair at Mulago Hospital, and data were collected at baseline at 2 weeks prior to hospital discharge and at 3, 6, 9, and 12 months following surgery. We conducted data collection in person for our baseline and 2-week data collection, and over mobile phone for all follow-up. Participants were provided with phones and airtime for this process. So moving on to the measures that were used in for our longitudinal cohort data collection. We captured sociodemographics, obstetric, and fistula histories at baseline, and at all data collection points, we assessed modifiable sociodemographics. Services received, physical symptoms, sexual and reproductive experiences. We included validated instruments assessing quality of life, incontinence, general health, depression, stigma, social support, and economic status. And we included our newly developed reintegration measure for validation. So before we get into the results of the longitudinal study, I'd like to just briefly discuss the development of our reintegration measure, because I will present the trajectory of reintegration score over time, and I just want to make sure that people are familiar with what we've included here. So our qualitative findings supported the development of an instrument that built on the Return to Normal Living Index, which is an 11-item measure commonly used among populations with stroke or traumatic recoverable brain injury. We identified the need to add a number of additional items on, and our resulting measure included 19 items that addressed the topic areas presented here on the slide, all of which fit within 4 larger themes of mobility and social engagement, meeting family needs, comfort with relationships, and general life satisfaction. Reliability and validity in the sample were high, and we anticipate that our measure analysis manuscript will be published very soon. Moving on to the results of the quantitative component of our study, this table describes the characteristics of our 60 quantitative participants. The median age of participants was 30 years old. Median age at fistula was 25. Participants were largely married or living together with partners at baseline, and most had not completed primary level education. In terms of financial support, just under 1/3 were dependent on themselves, 40% on a husband or partner, and about 1/3 on others. The majority of our participants had vesicovaginal fistula only, and then not presented, but also important for this presentation, is the length of time that participants had lived with fistula. So 13% of our sample had fistula for less than 1 month, 30% between 1 and 3 months, 13% between 3 to 12 months, about 11% between 1 to 5 years, and then 28% had lived with fistula for more than 5 years. The majority of our quantitative study participants were from central Uganda, with a few from eastern Uganda. We had excellent retention across all of our follow-up data collection points. Retention was 98% at 3 and 6 months, 92% at 9 months, and 97% at 12 months. There were 2 participants that were ultimately lost to follow-up at 12 months. One had moved internationally, and the other was no longer in contact with any family members, and we weren't able to track her. Now I'd like to present the physical health findings from our longitudinal study. Next slide, please. This graph presents the self-reported general health status across 4 categories: excellent, very good, good, fair. At baseline, self-reported general health was fairly low, with all participants reporting their health as fair or poor. We noted an impressive transition in the distribution of self-reported general health over the 12-month follow-up period, with dramatic reductions in the proportions reporting fair or poor, and large increases in those reporting very good and excellent. The next graph describes the proportion of respondents reporting experiencing certain physical symptoms across a follow-up period. As you can see here, the most prevalent physical symptom reported across the study follow-up was urinary incontinence. At baseline, 98% of women reported urinary incontinence. The proportion reporting any urinary incontinence dropped to 39% at 3 months, 33% at 6 months, ultimately ending at 34% at 12 months. So this indicates that 1/3 of our sample was still reporting urinary incontinence by the end of our 12-month follow-up. Next slide, please. While the prevalence of the other physical symptoms was, back please. Great. So this is the same graph that I've just presented, and I apologize, I see that the label is cut slightly, so we're not able to see what all of the symptoms are, but I had wanted to draw your attention to reports of these other physical symptoms. Even though they were lower than the proportion reporting urinary incontinence, there were women that continued to report a variety of symptoms throughout the 12-month follow-up period, all that were associated with the obstructed labor injury complex. And so at baseline, approximately 1/3 or more individuals reported experiencing general pain, foul-smelling vaginal discharge, pain on urination, general weakness, vaginal pain, and difficulty walking. Nearly 30% reported skin irritation. Report of the physical symptoms generally decreased over study follow-up. However, they were not completely resolved within this population. At 12 months post-repair, 14% reported general weakness, and then 7% each reported general pain, pain with urination, or vaginal pain. 2 individuals reported continued difficulty walking, and 1 individual each reported vaginal discharge and skin irritation persisting. Next slide, please. So now we'll move on to our psychosocial health indicators. This graph presents the mean value of the validated scales representing psychosocial health status across our population. I'd like to note that although all of these measures were on different scales, I have standardized them to represent a range of 0 to 100. At baseline, we see lower self-esteem and higher levels of depressive symptoms and all types of stigma. Across time, the mean level of depressive symptoms and stigma declined, indicating improved psychosocial health. and the mean self-esteem value increased. The patterns presented here suggest that the largest gains in self-esteem were seen by 6 months, while reductions in depression and stigma were largely achieved at 3 months post-surgery. The level of depressive symptoms at 12 months post-repair corresponds to approximately 12% prevalence of depression in this sample. So what I'd like to highlight here is that although we've seen some impressive increases in psychosocial health, we do see some persistent stigma, particularly negative self-perception, and we see that self-esteem standardized after about 6 months. Thank you. Next slide. Similarly, we saw improvements across all domains of quality of life across the study follow-up. The increases in quality of life were steepest for overall quality of life and for psychological health across the first 6-month period, slightly less steep for physical health, and less so for environment and social relationships. Again, the scale here is standardized to a range of 0 to 100, and while we see substantial improvements in quality of life, we note that the values at 12 months are all clustered within that third quarter between 50 and 75. Finally, I want to present the standardized reintegration score. So this is the measure that we developed and implemented in our longitudinal study, and the trajectory of mean integration value also shows a significant steep preliminary increase through 3 months post-surgery, followed by relatively stable value from 3 months through 12 months. The mean reintegration score was 33 at baseline. It increased to 70 at 3 months, 78 at 6 months, 75 at 9 months, and then 78 at 12 months. So now we'll move on to our sexual and reproductive health outcomes. Next slide, please. The proportion of women who reported being sexually active within our cohort increased over time and was just under half of our sample by 12 months post-fistula repair. The distribution of reported satisfaction with sexual life across the follow-up periods varied. And we observed reductions in those indicating that they were very dissatisfied and increases in those indicating satisfied or very satisfied across time. However, at 12 months, half of the participants reported being either very dissatisfied or dissatisfied with their sexual lives. Among individuals who reported being sexually active and not desiring pregnancy at that time, we asked about use of family planning, and responses indicated a high unmet need for family planning among this population. At 6 and 9 months, approximately 60% of sexually active women who did not desire pregnancy were not using any form of contraception. Some uptake occurred between 9 and 12 months, as you see that that large dark pink on the bottom reduces from about 60% to 33%. However, 1/3 of the population in need of a contraceptive method reported not using anything for pregnancy prevention at 12 months. Next slide. Given our small sample, we only recorded 7 pregnancies across our follow-up period. Although this is a very small number to draw any inferences from, we did have a concerning number of adverse outcomes that I would like to describe. 3 of the 7 pregnancies in our sample were spontaneously aborted at 3, 6, and 7 months gestational age. One of the women had had a history of spontaneous abortion for previous pregnancies, yet had no clear medical diagnosis, but the other 2 had no identified cause. We had 1 stillbirth. This was among a woman who indicated a delay in departing for delivery and who delivered vaginally instead of via cesarean section. 2 infants were live born and healthy. However, both were delivered vaginally instead of via cesarean section, as is recommended following fistula repair. And 1 pregnancy was ongoing at the time of this study end, so we don't have follow-up information here. Next slide, please. So the overall implications of these results suggest that women improved significantly physically and psychologically following fistula surgery. However, in our small sample, we had evidence that physical and mental health sequelae associated with the prolonged obstructed labor persisted even through 12 months post-surgery. And this suggests the need for evidence-based programming to adopt a more holistic approach for optimizing post-repair outcomes among women, including a greater level of services meeting the varying needs that women develop during this follow-up period, and increased level of follow-up generally. This is supported also by our findings of high unmet need for family planning and adverse pregnancy outcomes. Targeted interventions including counseling, health education, physical and occupational therapy, and economic assistance for women and their families could enhance women's post-repair recovery and family and community reintegration. However, further work is necessary to confirm the generalizability of these findings across different populations and to improve the evidence base of post-surgical interventions. So that concludes my presentation. I would like to just acknowledge our study participants and our funders, the National Institutes of Health, the Fistula Foundation, and the Fistula Care Plus program. Please feel free to direct any follow-up questions to me as they come following this webinar to my email. Thank you so much.
Oh, okay. Alison, thank you for an excellent presentation and your forbearance with our presenter mode here in GoToWebinar. I promised you it was, we're trying to fix that now, but thank you so much for persevering through your excellent presentation. Our next speaker is joining us remotely also, and he's based in Guinea, Conakry, Guinea, but he happens to be in the same time zone today. We're lucky to have Mr. Moustapha Diallo, who's the program manager and country representative for EngenderHealth in Guinea. He has provided leadership, management, and technical support to EngenderHealth's reproductive health initiatives in Guinea, and he has nearly 40 years of experience working to address inequities in health in access to health services. Mr. Moustapha, can you take the microphone?
Yes, okay, thank you. Okay, thank you, Bethany. Okay, let's talk about the overview of the EngenderHealth fistula and reintegration work in Guinea. EngenderHealth is currently implementing the obstetric fistula component of a 5-year USAID-funded health service delivery project, which is led by GPAIGO. EngenderHealth ensures that high-quality routine obstetric fistula treatment and reintegration services are offered at 6 regional and public hospitals. During the past Fistula Care project from 2007 to 2013, EngenderHealth successfully implemented a multifaceted reintegration strategy for patients, including a social immersion program and economic reintegration support. This strategy is being replicated by the current health service delivery project. To strengthen reintegration for fistula patients, EngenderHealth was able to develop strategic partnerships with local government, the communes around the fistula repair sites, as well as the National Ministry of Social Affairs and Women Promotion. This has built a supportive environment for reintegration. The goal of the social immersion program is to help women receiving fistula services reintegrate into family life and society after receiving clinical care. The program offers each woman discharged from hospital after fistula repair the opportunity to stay with a volunteer host family for 2 to 3 weeks. During this convalescence period, the women make a gradual and smooth return to normal life with the support of the host family. The role of the host family is to gradually involve the visiting woman into family activities and social occasions. These are often activities from which they have been excluded for a long time. During the stay, host families are honored through several special visits from the mayors or their representatives, along with rural radio stations. Host families are interviewed about their experiences with women, and their messages are broadcast to sensitize communities on fistula and fight against stigmatization. The social immersion program was evaluated in 2016, and the evaluation report noted, quote, "The testimonies of treated women clearly demonstrate how the project transformed their lives. From living hidden, away from her community, each woman is now back to where she always wanted to be, in the heart of her family, pursuing her own livelihood and taking part in everyday life." End quote. Now, why reintegration efforts are important? I fully agree with this statement from the study protocol. Quote, "It is impossible to erase the experience of obstetric fistula, regardless of their new physical status after repair. Women returning from obstetric fistula repair may be returning to an environment which has been hostile to them, and it is unknown to what extent reintegration parallels pre-fistula status." End quote. I strongly believe that comprehensive obstetric fistula projects should go beyond surgical repair, because for those women who live at the rhythm of community interrelations, social isolation is an infinite evil and more painful than the physical incontinence. In addition to these social issues, we cannot assume that women's physical or mental health has been fully restored or is at an optimal place merely because they received surgical services. And how OSA program can use the information from this study. While we have been able to interview women in the context of sexual studies to ask about their perception of reintegration support, we have never had a standardized tool to help us understand women's status and well-being in a comprehensive way. The measurement tool developed from this study would be useful to evaluate the social reintegration program. For example, we can assess how successful our multi-phase post-surgical reintegration strategy is by comparing women who have participated in reintegration services to those who have not at different time points following fistula repair. Without doubt, this tool will foster evidence-based programming for obstetric fistula projects. Thank you.
Well, Mr. Diallo, thank you so much for that important context from Guinea as to how this research can be used and some ideas on Alison's presentation. That's really provides some good context and rich discussion for us today. I'd like to remind all of our participants that we have the comment box. You should see it there in your GoToWebinar, and we are really welcoming questions. We haven't received any questions yet, and if you have any, please kindly include there in the box. We'll be addressing those later. Let us, before we take some questions and I have some questions myself, and before we go there to questions that are coming in, first I see here that we have some colleagues from DoveNet, a partner that we're working with in Nigeria, and want to welcome them. Thanks so much for joining us today. And I also see someone from Bangladesh has signed in. I know it is very late, or very early, I suppose, for you. Thank you so much. It's such a pleasure to have so many colleagues represented here today on our webinar. So we also have comments from the program manager in Uganda, Dr. Rose Mukisa Bizobora, and we thought it better to record her comments and play them, given that she's in Uganda, and we just wanted to make sure that we didn't have any kind of technical difficulties. So I'm going to turn it over to Dr. Rose. She's a medical doctor and public health specialist. She studied at the Université Libre de Bruges in Brussels, Belgium for her master's, and Imbara University of Science and Technology in Uganda, where she attained a bachelor's of medicine and surgery. She has previously served in various capacities in Jinja District local government, at the Makerere University School of Public Health, the African Medical and Research Foundation, and she's currently at EngenderHealth, this country manager Uganda office. Rose derives her passion from making a difference in the lives of women, children, and their families, and she's recorded some comments for us to listen to on Alison's research and presentation. So let's hear from Dr. Rose.
Good afternoon and good evening to all those who may be listening in. I am Dr. Rose Mukisa, EngenderHealth Uganda Country Office. I must say that I'm happy to contribute to this important discussion, which indeed speaks the work we do in Uganda on fistula. At the same time, I wish to appreciate the efforts of Alison and the teams from Makerere University and Mulago National Referral Hospital. So from the Uganda program perspective, I am excited to learn from the findings of this study. Several thoughts come to mind as I think about how we can apply this learning. In Uganda, we do have very high success rates for fistula repair, up to 95% at some facilities. However, these percentages are purely clinical and refer just to fistula closure at the time of discharge. So it's interesting to learn, appreciate, and define success as perceived by the patient and across a range of physical and mental health and well-being issues. This certainly can inform programming and possibly messaging going forward. The findings on mental health, for example, suggest that mental health services need to be integrated into fistula care. This is something that Fistula Care Plus Uganda has recently started working on. But the study findings may provide suggestions for when mental health or psychosocial services should be provided or offered to fistula patients to be most effective. At the same time, it's very interesting to see the time post-repair when there seem to be dramatic improvements for fistula patients and when those improvements seem to stop. This suggests that it's important to find ways to retain contact with fistula patients after discharge, not just to monitor repair, success, or breakdown, but to ensure that patients can continue to access the health and psychosocial services they may still need. Similarly, our work in Uganda, presented at the last International Society of Obstetric Fistula Surgeons meeting in Nigeria, has also found that there is an enormous amount of unmet need for family planning among women who have received fistula repair. This study confirms this issue. Along with the adverse perinatal outcomes, it suggests that follow-up after fistula repair are not just counseling and referral during the fistula repair episode of care is essential to support fistula patients' family planning and maternal health service needs. I am thinking about follow-up. We have often thought that we need to rely on face-to-face interaction. We have imagined that face-to-face follow-up is more informative and contextualizes the information we receive from patients or clients. In other words, the interviewer links and analyzes responses in reference to expression. However, cell phone follow-up will inform use of such technology if found useful and handy going forward. In addition, the study has focused on the longer-term outcomes for women who have been successfully repaired. However, we know that some women will still have fistula that is deemed incurable. And we have been working on research with the Ugandan organization Terode to understand the effect of reintegration services for these women. It would therefore be very interesting to apply the measurement tool developed through this study to understand the trajectories of women deemed incurable as well. I noticed also that a good percentage of women, about 75.8% of them, are either currently married or living together with partners. This is an interesting figure, as it's often perceived that all women with fistula are abandoned. I see men in such relationships providing an opportunity for them to be used as ambassadors and indeed can contribute to a positive or supportive change for such relationships. Finally, it will be interesting to know the outcome of the two women who had vaginal delivery, given the current counseling practices which promote cesarean section after fistula repair. On this note, I wish therefore to once again thank Alison and the entire study team for the informative sharing, and thank all those that have listened in. Thank you.
Great. Okay. Thank you so much, Rose, for those observations and for recording it. It was really great to hear your voice on today's webinar. I really appreciate that extra effort. So I'm going to open up for some Q&A now. We're getting quite a bit of questions through our comment boxes. Thank you so much to the active participants that we have here today. We may not be able to get to all of your questions. We have maybe 5 or 6 minutes for some Q&A. So let's see, let's start here. Alison, I really appreciated that the survey tools and the research asked both about sexual activity and satisfaction with sexual life, which are not the same thing, and that you also tracked family planning data that's very important to our project. So let's start with our first question here. Any correlation between post-operative sexual life, and especially the timing, and poor outcomes in the study population? And when we talk about poor outcomes, we're talking about poor perinatal outcomes. Any thoughts on that?
Great, sure. So my first thought is that we just have very low numbers of pregnancies in our sample, so I don't think that we really can answer this, although I know that the literature is suggesting that similarly high rates of adverse reproductive outcomes post-repair, and I think this is an area that is continuing, that our knowledge will continue to be developed. So it's definitely something that we hope to look into. Unfortunately, we're not able to assess with with 7 pregnancies.
Sure. No, that's an understandable, but maybe can spur some further research. Okay. Let's see. Next question here is psychological improvement observed following intervention? In other words, is there a correlation between intervention services and psychosocial well-being?
This is a great question, and we have only done some exploratory analyses in our data. We're limited by the fact that given the length of our survey instrument, our questions around which services were received by women were really just one phrase: did you receive counseling services? Did you receive other social services? Did you receive economic services? And our policies are not showing a large effect. However, I would really caution about interpreting this finding, given the fact that women who are most in need of services are probably the ones that are being prioritized for services, particularly in environments where less resources are available. And then secondly, because we don't have any concrete measures of intervention, coverage, dosage, fidelity, etc.
Mm-hmm. Okay. So
we have, I'm sorry, can I just say one more thing there? Yes. What we do see in some of the literature that has come out around counseling programs, which really is the area that has, I think, maybe 2 publications in the scientific literature, we do see significant improvement in women's mental health with counseling programs. So there is evidence of this, and I think that it would be great for the programs that are implementing this and other reintegration services to measure them and share their findings so that we can continue to build the evidence base on best practices for holistic models of fistula care.
Sure, and it would be interesting too to review the existing curriculum to see what is covered in terms of sexual satisfaction and sexual activity, family planning use, things like that. See what's included in there. I know there is a focus on regaining continence, which is completely understandable, and that seems to take up a lot of the focus and effort. So it would be curious to see what is included in the curriculums. Okay, we're getting so many good questions. I'm going to keep going, Alison, if that's okay.
Sure.
Great. Okay, so I'm going to ask these 2 questions back to back. Is there an intention in the study to continue follow-up after 12 months? And if not, do you recommend this for programs? And then second question is, how is sexual activity measured at different time points?
Sure. So in response to the intention to continue follow-up after 12 months, we currently don't intend to continue follow-up after 12 months, and this is largely based on a lack of funding. I do think that following women across multiple years would be very useful, particularly given these preliminary findings that women do have higher rates of adverse perinatal outcomes following fistula repair, and because many women are not experiencing pregnancy within that first year after fistula repair, we are not able to really develop robust estimates of how large this increased risk is to then move into development of solutions for trying to manage and reduce this risk.
Right.
So I do think that would be a great contribution to the literature. And then in response to your second question on how is sexual activity measured at different time points, this is a question that I have thought a lot about, because clearly there's a lot of different components about sexual activity that are very relevant for the population of women that are undergoing fistula repair. We limited our measurement in our survey to whether or not they had resumed sexual intercourse and that was self-reported. So we did not ask about frequency, we didn't ask about any other qualities of that.
I see. Okay, and before I go to Moustapha with a question, another one for you, Alison, that's related to that. How is the question about satisfaction or dissatisfaction with sexual life, how was it asked or phrased?
Great. So I'm just going to pull that up quickly. And the phrasing, thanks for bearing with me.
Sure, of course, of course. I can also, let me go on to Moustapha and we'll come back to you with this, with your thoughts on that. Would that be okay?
That would be great, thank you.
Sure, yeah, listen, I also want to say to everyone, we're having such good, rich questions in the dialogue box. Thank you so much. I really appreciate everyone's questions and interests. Because of the time constraints that we have today, we're going to put up a blog post in the coming days with Alison's comments and the other comments we're getting for Moustapha and Rose. And we'll address those. We might not get to them today, but I really appreciate everybody's participation. So quick question for, or a question rather, for Moustapha, if you can still hear me, I hope we are connected. So yeah. One of the inclusion criteria for participants was residing in a community with cellular coverage. And for very remote women who may not have access to cell phones or do not live in an area with coverage, how can programs and health workers reach these women? And do you think the findings are relevant for very excluded women? Do they have different experiences?
Well, I see two questions here. First of all, how can programs and health workers reach these women who live in remote areas who may not have access to cell phone? I assume every program has its own strategy. I can share the Guinea experience. We have established a vibrant network in charge of identifying and referring fistula women to repair site. The network comprises designated focal points at certain locations. They conduct regular outreach activities to identify fistula women. Secondly, the formal health system. Women are identified and referred throughout the health pyramid, from health post to health center to district hospital and to regional hospitals. And the rural radio plays a vital role in reaching out fistula women. And finally, the staff from the health service delivery project from the repair site coordinate the referral system. And the synergetic work of this aforementioned actor helps identify fistula women wherever they live. The second question is, because of the small sample size of the study and the characteristic of the study population, whether or not findings are relevant to women living in remote areas. I think the response comes from the study protocols. Quote, due to the exploratory nature and small sample size of our study, our result will not be generalizable. However, a large multi-site follow-up study evaluating the measurement tool is planned. This is a response I can see from the study protocol.
That's great. Great, and thank you for that. That was really comprehensive. Especially, I appreciate your mentioning the rural radio. We know that, yeah, that can in remote communities have a saturation point beyond the cell phone coverage too. So we need to be thinking, not forgetting rather, radio that served us so well for so long. Thank you for that. So Alison, back to you. Were you able to pull up those questions?
I have. Thank you so much. For your patience with that. So the question on sexual satisfaction really just reads, was taken from the World Health Organization Quality of Life Measure, and is a Likert style question reading, how satisfied are you with your sex life? And so response options include very dissatisfied, dissatisfied, neither satisfied nor dissatisfied, satisfied, and very satisfied. So it is also, again, within the context of survey research, it is not a very nuanced question. However, we have conducted series of qualitative interviews with a subset of participants in our cohort study at 12 months post-surgery, and we're actually just starting to look at that data now. We just completed that at the end of this 2016. So I do think that we'll be able to pull some more nuanced information about the processes behind and decisions behind resuming sexual activity, around deciding whether or not to use family planning and challenges therein, as well as satisfaction around sexual lives. So to be seen soon.
Right. That is great. It would also be look at answers to those questions compared to women who have never reported fistula, and to see, you know, if women have different experiences. Okay, I'm going to push through. I'm going to ask one more question before we close, Alison. I can't let this one go. It's too good. So our colleague Alex Delamu, again, also from Guinea, and he points out that we have also seen adverse outcomes both for fistula recurrence and reproductive health outcomes in our longitudinal data in Guinea. He was on some research there. And given the similar experiences in Uganda, what is needed to improve women's health and prevent these adverse outcomes post-repair? So it's such a juicy question. I don't know, it's a big answer. I don't know if you have a really quick soundbite for us.
Well, the quick soundbite here really is the need to develop or modify the model of fistula care into a continuum of care that's addressing a holistic model and ensuring that women are continually linked to the maternal and reproductive health services that they may need following repair, given the rates that that Alex has identified in his study with a much larger sample size than what we have had in our Ugandan data. I think that the evidence really is becoming robust that women are at higher risk of adverse outcome, and they need to be linked to healthcare services. So that needs to be addressed from both a service provision and a demand creation perspective.
Great. Okay. Thank you. I know that was a very good soundbite in such a short time for such a big question. So I'm afraid that I will have to cut us off, though. Again, we're going to collect all of the wonderful questions from great participants and do a blog post for everyone. So please keep in touch or keep tuned on our website and on our Twitter for that. But before we close, I have an important and exciting announcement to share. This week, EngenderHealth's Fistula Care Plus project will publish an important resource, the Surgical Safety Toolkit, which will advance safe surgical practices and improve health outcomes for women affected by fistula. Along with the toolkit is an orientation video produced by Medical Aid Films, which shows the ease of using safety checklists and tools, and features interviews with fistula surgeons and nursing staff from a leading teaching hospital in Nigeria. The tools and video are currently available in French and English, and we'll be sharing these with our distribution networks, including colleagues at ISOFs and midwifery associations around the world. I really invite you to visit our website, fistulacare.org, and follow us on Twitter at FistulaCare. All of the toolkits and the checklists and the video that I just mentioned in French and English are posted on the website, and we will also be posting today's webinar and the resources associated with today's webinar and the previous webinars that the Fistula Care Plus and EngenderHealth has hosted is already on our website, and I encourage you to look those over. I want to thank again Dr. Alison El Ayadi and Moustapha Diallo and Dr. Rose Mukisa for their presentations today, and especially again, thank you, Alison, for your forbearance with the small technical difficulties. Appreciate that. Thank you so much for joining us today and being a part of this, and please contact me. I'm Bethany Cole if you have any question or follow-up. Thank you.
Thank you.
Thank you.